session is on hypertrophic cardiomyopathy from diagnosis to prognosis, and I'm going to request the right person to be the chair, that is Dr. Ajay Bahal again. Dr. Sapru is not around. Dr. Galotra also could not make it. He's stuck in an intervention. And somebody who's as free as I am is Dr. Sudhir Saxena. Please come and chair the session. We always find time to do something. He is a wonderful person. He is an intervention cardiologist at Max Hospital, my favorite. And uh, he is an excellent photographer. He is encyclopedia, surprisingly, to all Indian Hindi songs. You give him a song, he'll tell you which singer, which movie,
Enough, sir.
which
Thank you.
the musician, everything, lyricist, all, right? So he is the chat GPT of Indian Hindi songs. So the Dr. Sudhir and Dr. Ajay, please introduce Dr. Alagesan. Can we have the slide, Dr. Alagesan? You have. You don't have the. All right. All right.
Good evening, sir, and we look forward to your talk on hypertrophic cardiomyopathy, diagnosis to prognosis. And let me just add that I'm a very lowly cardiologist in the sense that I don't do too much of echocardiography. The only echocardiography I'm exposed to is related to the general practice of interventions and all other things probably. So I may be a misfit in this echocardiography conference, but Dr. UP has been kind enough to call me. So anyway, I'll learn a lot from you. I continue to learn, as he says.
Thank you. Thank you, Dr. UP Singh, for inviting me for the second time to Chandigarh. So last time I enjoyed the conference very much. So hopefully I will learn something from the other speakers and from you all in this meeting. And Dr. Ajay Bahal, we are going to meet again in the CSI. So you are going to give a talk on genetics of hypertrophic cardiomyopathy. I mean, going to give a talk on sudden cardiac death in hypertrophic cardiomyopathy. So this talk is about mainly about the diagnosis of hypertrophic cardiomyopathy. And even though UP Singh has termed it from diagnosis to prognosis, the treatment and prognosis, I'll be just touching it, and I will not be discussing in details. But the diagnosis part, we'll be discussing in details. And this is our book, Hemodeccardiography, which was written in 1980. Wisdom lies in the not in the amount of knowledge acquired, but in the degree of its application. So whatever you learn, try to apply it in day-to-day life. This is a saying from Dr. M. Vivekananda. Hypertrophic cardiomyopathy is actually a fascinating disease because it's not quite uncommon. It's the occurrence is 1 in 500 people, and the genetic abnormality may be present in 1 in 200 to 250 people. So if you take the entire population, so hypertrophic cardiomyopathy is not an uncommon disease, and it's one of the best doctor's disease. So it's the cardiomyopathy specialist, valvular heart disease specialist, coronary artery disease specialist, arrhythmology specialist, genetics, heart failure, multimodality imaging, interventional cardiology, and sports medicine. All these branches of medicines are involved in treating and managing patients with hypertrophic cardiomyopathy. Cardiomyopathy definition itself, Dr. UP Singh would have touched. The myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, congenital disease, sufficient to cause the observed myocardial abnormality. So this applies to all the cardiomyopathies like dilated cardiomyopathy, hypertrophic cardiomyopathy, infiltrative, and other types of cardiomyopathy. In hypertrophic cardiomyopathy, the main diagnostic criteria is the left ventricular wall thickness should be equal to or more than 15 millimeters in one or more myocardial segments. This can be measured by echocardiogram or by CT or by an MRI. MRI will be the best one if you want very accurate measurements of the thickness. In children, the left ventricular wall thickness should be more than 2 standard deviation above the predicted mean. So this is the exact criteria for diagnosing hypertrophic cardiomyopathy. In relatives of a patient who is already having hypertrophic cardiomyopathy, even unexplained increase in left ventricular wall thickness of more than 30 millimeters may be indicative of hypertrophic cardiomyopathy, and they should be followed up. All of you know the etiology of the hypertrophic cardiomyopathy. It is the genetic abnormality in the sarcomeric gene. So there are a number of genes, there have been more than 100 genes have been described. But the most common one is the myocardial binding protein C gene and the beta myosin heavy chain gene. So this actually accounts for the major number of people with hypertrophic cardiomyopathy. Of course, troponin T gene also is responsible in a quite a few number of patients. If you take patients with hypertrophy of the left ventricle, usually the sarcomeric protein gene mutation producing typical hypertrophic cardiomyopathy forms about 40 to 60% of the people. In 5 to 10% of the people, it is non-genetic cause or gene defect which is other than sarcomeric genes are involved. There are a number of genetic abnormalities which can mimic hypertrophic cardiomyopathy, and we have to be aware of that because some of the abnormalities are now there are some treatment available. So we have to assess the patient to identify the non-sarcomeric genetic type of left ventricular cardiomyopathy. Also, we have to diagnose conditions like amyloidosis and other conditions which can mimic hypertrophic cardiomyopathy. And even whatever investigations you do, 25 to 30% of the people, you may not be able to find out any genetic defect or other non-sarcomeric genetic defect also in some of the patients. So this actually classifies the people with hypertrophy of the left ventricle. The genetic sarcomeric genetic cause is the one which we are going to deal with. Other genetic type diseases like storage diseases, the neuromuscular and mitochondrial diseases, and malformation syndrome like Leopard syndrome, Noonan syndrome, and Castello syndrome. All these conditions can produce hypertrophic cardiomyopathy. So when you see a patient first time with hypertrophy of the left ventricle, most likely it is going to be a hypertrophic cardiomyopathy. At the same time, you say about say 1/3 of the patient, 1/10 of the patient, or 1 in 10 or 1 in 20 will have causes other than a sarcomeric gene mutation producing hypertrophic cardiomyopathy. How will you identify them? So usually we follow the red flag approach. So the red flag approach, identifies the pedigree and the type of transmission, the symptoms, associated symptoms like deafness, muscle pain, paresthesia. During physical examination, again, you identify certain symptoms which are not present in hypertrophic cardiomyopathy. And the ECG features, especially pre-excitation syndrome and AV block, when they are present, it indicates some other disease. Laboratory investigation and echocardiographic features. So all of these things can identify non-HCM hypertrophy. So we have to follow this approach strictly if you want to identify this 1 in 10 or 1 in 20 conditions which produces hypertrophic cardiomyopathy. The hypertrophic cardiomyopathy itself was described in 1958, and in the early days, we used to do the angiogram for identifying the left ventricular wall thickness and the other obstruction, etc. Later on in the 70s, the echocardiographic features were described, and in the 80s came the two-dimensional echocardiography, which clearly showed which segments are involved or which segments are hypertrophied. The MRI was able to give a clear delineation of the left ventricle and the muscle thickness. And now recently we can identify the portions which are fibrous by using the late gadolinium enhancer. So this is the stages through which we have gone through. And this is one of our earliest angiograms showing mid-ventricular obstruction. A patient with hypertrophic cardiomyopathy, mid-ventricular obstruction, and a left ventricular apical aneurysm. The same patient's echo. This was done in 2003. You can see the markedly hypertrophied left ventricle. In the short axis, you can identify again the marked hypertrophy of the entire left ventricle. And you can identify the mid-ventricular obstruction with apical aneurysm, left ventricular apical aneurysm. When you switch on the color, you can see the narrow jet through the mid-ventricular obstruction. And this is the continuous Doppler across the mid-ventricular obstruction. And later on came the left ventricular, cardiac magnetic resonance imaging, which clearly gives you the thickness of the left ventricle and left ventricular apical aneurysm. Left ventricular apical aneurysm is one thing which is when it is small, it's very difficult to diagnose by echo alone, and is cardiac MRI is extremely useful for identifying the aneurysms. So this conditions, we have to have the ability in observation, ability in deduction, ability in psychological and environmental reconstruction, ability to spot the inconsistencies and to practice this culture. So like a good detective, the doctor should be a good clinician to go through all the steps and identify the hypertrophic cardiomyopathy. And coming to the hypertrophic cardiomyopathy itself, the Moran's classification, there are a number of classifications based on echo, MRI, etc. But the most common one is the Moran's classification, which divides the left ventricular hypertrophy into sigmoidal HCM, reverse HCM, apical HCM, and neutral HCM. So this is a patient with sigmoidal HCM. There is marked hypertrophy of the basal septum with left ventricular outflow obstruction. In why you have to identify? Because in 10% of the people, the myofilament, the sarcomeric gene is positive. And in the next type, the reverse curvature HCM, this is the one which presents with marked hypertrophy often, and 80% of the people have the genetic abnormality. And the third type is the apical HCM. 30% of the people with myofilament gene, they are gene positive. You can see the marked hypertrophy and obliteration of the left ventricular apex by the hypertrophy. And this is the neutral HCM. Again, the 40% of the people are gene positive. So any type can present with or without obstruction. So sometimes the obstruction itself can be in different regions involving only certain segments. In this patient, you can see the inferior septum and the inferior wall are hypertrophy. And in this patient, actually, the anterior septum and the left ventricular anterior wall are hypertrophy. So the hypertrophy can vary from person to person. Oh, right, it's not running. 1 minute. This is the one where, see, the inferior septum and the inferior wall are hypertrophied. And in this patient, you can see the anterior septum and the left ventricular anterior wall are hypertrophied. This is a patient with hypertrophic cardiomyopathy, Japanese type, the Yamaguchi type, where the left ventricle apex is markedly obliterated, and there is the left ventricle cavity itself appears like a spade. So usually these are the people who have left ventricular hypertrophy and marked T-wave inversion. The next classification is obstructive and a non-obstructive type of HCM. So this is a patient with non-obstructive type of HCM. You can see the left ventricle is uniformly hypertrophied in all the segments, and the left ventricular apex is little obliterated, and there is no mid-ventricular or left ventricular outflow gradient. And this is another patient with hypertrophic obstructive cardiomyopathy, marked hypertrophy of the interventricular septum, marked systolic anterior motion, and there is a severe dilatation of the left atrium indicating that the patient has got severe hypertrophy and also mitral regurgitation. You can see the left atrium is hugely dilated. These people are actually in risk of developing left atrial fibrillation. So this is the typical the knife-like appearance of the left ventricular outflow obstruction, and this is the mitral regurgitation. This is another type of another patient with mild to moderate hypertrophy of the interventricular septum, and this patient has a systolic anterior motion of the anterior mitral leaflet. In this patient, you can see the resting, there is a no gradient across the left ventricular outflow tract. With the valsalva maneuver, you can see a significant obstruction, almost 4 meters appearing with the valsalva maneuver. So in patient with no obstruction rest, you have to do some provocative maneuvers to find out whether there is a gradient at, say, after provocation. One of the provocative maneuvers is valsalva maneuver. This is another patient again who has a little obstruction. That's the velocity is just 2 or 2.2 meters. After an ectopic beat, you can see a significant obstruction. Again, this is provoked by the ventricular premature beats. This is the echocardiographic equivalent of broken barrow brown wall phenomenon, which is described in cardiac catheterization. This is a typical appearance in the mid-ventricular obstruction. You can see the left ventricle is hypertrophied, the left ventricular middle portion is markedly narrowed, and this may be present with apical aneurysm or without an apical aneurysm. Actually, in this patient, it's very difficult to identify the left ventricular aneurysm because it is very small. But in the Doppler pattern, you can see the Doppler, going into the diastole. Here you can see the Doppler is going into the initial portion of the diastole. Whenever the obstruction Doppler spills over to the diastole, that it indicates that the patient is developing the left ventricular apical aneurysm. This is another patient with mid-ventricular obstruction where you can clearly identify the mid-ventricular obstruction and there is a significant left ventricular apical aneurysm. And this is the typical pattern which has been described, the lobster claw appearance. This is the obstruction during systole and this is during diastole. This is the diastolic flow. And this one appears like a lobster claw. Whenever you see this pattern, it's almost diagnostic of mid-ventricular obstruction in a patient with hypertrophic cardiomyopathy and left ventricular aneurysms. And this is the same patient's MRI, which clearly identifies the left ventricular apical aneurysm. The other thing is sometimes the obstruction can be present during, say, in the left ventricular outflow tract. There is a left ventricular outflow tract gradient of about 2.5 meters, and also there is a gradient across the mid ventricle. So sometimes obstruction can occur at both sides. The other phenotypes is the cardiac failure phenotype. One is preserved ejection fraction and patients with reduced ejection fraction. This is a patient with marked hypertrophy of the left ventricle, and there is a systolic anterior motion, and there is a left ventricular outflow obstruction also. You can see a gradient of about 4.5 meters across the left ventricular outflow tract. And if you see the Doppler across the LA outflow, you can see a tall E wave and a small A wave, and there is an L wave also. And the S waves in the E waves in the septal and lateral tissue Doppler are markedly reduced. The pulmonary vein shows a small S and a large D. All these features are indicative of the patient having type 3 diastolic dysfunction with an elevated left ventricular diastolic pressure. So in this patient with hypertrophic cardiomyopathy, when you get a features like this is indicative of heart failure with preserved ejection fraction. This is another patient whom we are following. Actually, he had a normal ejection fraction to start with. He has developed a reduced ejection fraction and cardiac failure. So in this patient, you can see the typical type 3 or the restrictive pattern of diastolic dysfunction, and the IVC is dilated with minimal respiratory variation, and there is significant pulmonary hypertension. The pulmonary artery pressure is almost 70, 75. So these are apart from say the obstruction, we have to look into the left ventricular function, whether they have a cardiac failure with preserved ejection fraction or a reduced ejection fraction. Other abnormalities which has been described in hypertrophic cardiomyopathy are mitral valve abnormalities, especially long cardia of more than 40 millimeters. If they are present, it is often present in patients with hypertrophic cardiomyopathy. The other abnormality is here in this patient, the mitral valve, because it is hitting over the interventricular septum. This patient has developed infective endocarditis, and you can see a small mass over the anterior mitral leaflet, which is again hitting against the left ventricular side of the interventricular septum. So mitral valve vegetations can occur over the mitral valve. Sometimes it has been described over the point of the over the left side of the interventricular septum due to endocardium being eroded. There is another patient with hypertrophic cardiomyopathy who has rheumatic mitral valve disease. You can see the anterior and the posterior mitral leaflets are thickened. You can see a mitral stenosis and mitral regurgitation, and also a left ventricular outflow obstruction. Severe mitral stenosis, marked hypertrophy of the interventricular septum. So hypertrophic cardiomyopathy is so common that it can be associated with other diseases also. We have seen rheumatic mitral valve disease, sometimes in older people, calcific aortic valve disease, coronary artery disease, etc. can be present along with hypertrophic cardiomyopathy. So to say, you see, there is another patient. This is another patient where you can see a left atrial myxoma. So this is a patient with hypertrophic cardiomyopathy with an associated left atrial myxoma. This case was given to me from my colleagues in Madras Medical College. You can identify a large myxoma, but not producing significant obstruction in a patient with hypertrophic cardiomyopathy. We have seen PDA even hypertrophic cardiomyopathy. So any condition, you have to look for other conditions also when you diagnose hypertrophic cardiomyopathy. Abnormal papillary muscles is one of the common findings, especially with midventricular obstruction. The hypertrophied papillary muscle, which is inserted lower into the interventricular septum or into the left ventricular apex, and the hypertrophied papillary muscle produces often a midventricular obstruction. And during surgery, we have to do something. If we are going to do surgery for those patients with midventricular obstruction, we have to modify the papillary muscle also to relieve the obstruction. Because it's a genetic defect, there can be crypts also. Here you can see a patient with hypertrophic cardiomyopathy with crypts over the interventricular septum and the left ventricular anterior wall. And this patient had a midventricular obstruction. And you can identify the crypts by the cardiac MRI also. Here you can see the crypts in the interventricular septum and in the left ventricular apex. Cardiac MRI is one of the important investigation in patients with hypertrophic cardiomyopathy. At least when you see the patient for the first time, it is better to do cardiac MRI because it gives additional information about the extent of hypertrophy, the extent of fibrosis. It can also, there are some features in the echo and MRI which can differentiate hypertrophic cardiomyopathy from other genetic and non-genetic types of hypertrophy. So cardiac MRI is one of the additional investigation which you should always do it. This is another patient with the marked hypertrophy of the interventricular septum. Actually, his grandfather, father, and this is the son who had hypertrophic cardiomyopathy. Marked hypertrophy of the interventricular septum and the left ventricular anterior wall. There is mild hypertrophy of the other regions. And here you can see the hypertrophy. And this patient had a significant LVOT obstruction, and there was mitral regurgitation also. There is hypertrophy of the right ventricle also. You can see the right ventricular outflow tract is markedly hypertrophied, and the pulmonary valve is opening normally, and there is a 3 meters gradient across the right ventricular outflow tract. So this was a patient with left ventricular outflow obstruction and right ventricular outflow obstruction. In this case, the thing is not running, but this is a patient with hypertrophic cardiomyopathy with pulmonary stenosis in a patient with Noonan syndrome. Talking about the incidence of sudden cardiac death. So one of the prognosis, usually the patient if they present early in life, the prognosis is not good. When the disease presents later in life, always the prognosis is good. if it comes in the 40s or 50s and all that, always the prognosis is good. The earlier the onset, the severe the hypertrophy, severe the obstruction, the prognosis is going to be not good. So depending, there are certain features in the echocardiogram which are indicative of bad prognosis or sudden cardiac death also. Two of the important thing is the left ventricular outflow gradient at rest, and also the left ventricular wall thickness. The left ventricular wall thickness, if it is more than 30 millimeters, usually they have a higher risk of sudden cardiac death. Also, left ventricular outflow obstruction of more than 50 millimeters again carries a higher risk. Apart from that, they have included the age, family history of sudden cardiac death, unexplained syncope, left atrial dimension, and a non-sustained VT in the Holter. These are the criteria which is used in the European Society of Cardiology scoring system. It's a complicated score. They they give weightage for each of the factors. Among this, the left ventricular outflow gradient and left ventricular wall thickness is actually it starts from mild to severe, whereas the other things are present or absent, the other criteria. Depending upon the scoring system, the score is comes to below 4, 4 to 6, or say more than 6. If it is below 4, usually the sudden cardiac death risk is low. So usually ICD is not indicated. If the risk is more than 6%, usually the sudden cardiac death is high, and these patients and ICD is indicated. Whereas when the ICD, the risk score is between 4 to 6, we have to look at the other clinical features. This is the one, the ESC score was the one which was initially described. Later on, the American Society of Cardiology and American Heart Association came up with additional criteria. These are called the risk enhancers. In the cardiac MRI, if there is late gadolinium enhancement of 15% or more, then it carries a higher risk. Left ventricular apical aneurysm, whatever may be the size, if it is present, the risk is more. And if the patient has developed left ventricular dysfunction and the ejection fraction is less than 50%, the risk of sudden cardiac death is more. So they have added these three criteria. So in the indeterminate patient with 4 to 6, if there are these additional risk factors are present, then it may be advisable to put a ICD. So placing an ICD is an individual decision which you have to discuss with the patient and then decide whether to put in an ICD or not. Putting an ICD in an unnecessary patient also it carries risk, because there can be infections of the leads, other complications, etc. So the placing an ICD in a patient with hypertrophic cardiomyopathy saves lives, and it should be taken as after a discussion with the patient. And of course, you know about the treatment. The treatment is medical, surgical, and other treatments are available like cardiac transplantation. And you know the newer drug which has revolutionized the treatment, but it is very costly, mavacamten, which can decrease the gradient across the left ventricular outflow tract. So these are the things which are available for treating hypertrophic cardiomyopathy. Thank you.
Thank you, sir. Fantastic images. I think each and every image was of very good quality.
Thank you, sir. And I think Dr. UP had said in the beginning, I have interest in imaging, although that's a different kind of an imaging that I do these days. So every kind of imaging actually attracts me. Just a couple of questions, sir, for the sake of the audience also. Number one, you said that all patients, once you have screened on the basis of echocardiogram and you have diagnosed this as hypertrophic cardiomyopathy, should undergo a cardiac MRI. Is it should, or is it that you can, okay, wait, or maybe if there are bad prognostic signs or there are patient is too symptomatic, only then you get it done? I'm just asking from a perspective of the commonly practicing physician, where the patient may or may not agree for an MRI probably, or it may be a costly procedure for the patient. So that is one question that I would like to ask you, sir.
In an ideal situation, it is a must.
Yes.
Because in an ideal situation, if there is no cost constraint, if when it is available, whenever you see a patient with hypertrophic cardiomyopathy initially, apart from the treatment part of it, you have to assess the sudden cardiac death risk because 40 to 50% of the deaths are due to sudden cardiac death, arrhythmia and sudden cardiac death. About say 20-35%, 20 to 35 is due to cardiac failure. About 5 to 10% is due to atrial fibrillation, thromboembolic complications, stroke, etc. So if you want to avoid sudden cardiac death, it's just the most important one, and you may be blamed if you have not discussed with the patient what is the risk and all that. After assessing the risk, there can be even say unforeseen sudden cardiac death. That is not a problem. But when you want to assess the sudden cardiac death risk, ECG, echocardiogram, family history, in younger people, especially exercise, and MRI. MRI because it gives definitely the cardiac MRI gives you the thickness of the left ventricular wall and also late gadolinium enhancement, and apical aneurysm can be diagnosed accurately. So a cardiac MRI in an ideal situation should be done in all the patients. The other thing is, once it is not enough if you assess the sudden cardiac death risk at the say diagnosis when the patient is diagnosed. Once in 2 to 3 years, you have to reassess the patient because the fibrosis would have progressed or the thickness would have become more. The risk also increases during the course of a few years. So say you have to assess the sudden cardiac death risk once in 2 to 3 years. You may do a Holter once in 2 to 3 years, which is a little easier. You may do a MRI also. So it's like that. You have to repeatedly assess the sudden cardiac death risk and also the cardiac failure risk. So whenever you say we encounter a patient with hypertrophic cardiomyopathy.
Are there any specific kinds of hypertrophic cardiomyopathies which are endemic to India as such? I mean, which are not seen elsewhere?
No, no, I don't think there is. It's the same which which
It's
is
the same which
encountered
you see?
worldwide. The
Okay.
only problem is previously they were used to say the hypertrophic cardiomyopathy you have to do a genetic test. That is a specific one. That it's not like that because there are a number of people with gene positive. They may not develop the disease or disease itself because the development of the disease depends upon other interacting features also. Only thing is if they have polygenic genes, more than 2 or 3 numbers genes type positive, the risk of sudden cardiac death is also more. That's hypertrophy also is more. So genetic testing also can be done. It also gives you some information about sudden cardiac death and the progression of the disease. But most of the thing which is covered by the genetics will be covered by the thickness, gadolinium enhancement, LVOT obstruction, etc. So additional genetic indicating only for indication for ICD will not be that much. Like that, there are certain ECG indicators of sudden cardiac death. Again, that is again covered by the other radiological, I mean MRI and the echocardiographic features. The abnormalities which are supposed to be present in patients who develop sudden cardiac death, like a patient with Q wave in the ECG, in a patient with hypertrophic cardiomyopathy carries a higher risk of sudden cardiac death. So usually those patients with Q waves usually have more fibrosis in the cardiac MRI. So that will give you an information. This is an additional information. Q wave present means at least in the patient with the Q wave, you should do a cardiac MRI and look for circadian intervention. Similarly, the LV global longitudinal strain. If the LV global longitudinal strain is more than 15, most probably they are not having that much of fibrosis. If the LV-GLS is markedly reduced, then you should do a cardiac MRI for that patient and look for the fibrosis in that patient. Because GLS alone is not accepted as a criteria for, say, implanting a pacemaker. But it can guide you. The ECG can guide you to MRI. The echo GLS can guide you to an MRI, which is a much more specific and accepted.
That I was about to ask you
Yes.
about GLS only in hypertrophic cardiomyopathy. And my third question, sir, which is I mean, we keep seeing as clinicians quite a few cases of apical cardiomyopathy every year with a typical pattern in the ECG. What is the prognosis of these patients? Because I think generally they carry a good prognosis.
Yes, usually they carry good prognosis. Except the Yamaguchi type, previously I also thought it is very benign disease. They have a good prognosis. But later, nowadays, they are saying it may also, the risk of sudden cardiac death is more with Yamaguchi type also.
Thank you, sir.
Okay.
Sir, can I have one question?
Yes.
So regarding mavacamten, what's your advice? Because as it is said, it really corrects the pathophysiology of fibrosis, myosin actin filaments, and the whatever the company has come with the drug, they have given many of the trials and the follow-up of many of the patients, saying that it is really worth to use this drug.
It's early days. There are two trials which have used mavacamten and the alpha campton. The other one, the second one also has come. So the mavacamten, only thing is you have to repeat the echocardiogram once in 2 months and look for left ventricular dysfunction developing. That's one thing. Otherwise, if you increase the dose to sufficient, level, the left ventricular outflow obstruction definitely decreases, and the patient's symptoms also definitely decrease. I have not used it, but I have attended say symposium on mavacamten. At that time, I have picked up the thing, and it can be used only for left ventricular outflow obstruction. There is off-label use for patients with mid-ventricular obstruction. So, but it usually is not indicated for mid-ventricular obstruction. It is not indicated for non-obstructive HCM. Only for left ventricular outflow obstruction, if there is a significant LVOT obstruction, mavacamten can be used. The advantage of the alpha campton is it doesn't produce that much of left ventricular dysfunction. That's what I was told. So the JC may be able to discuss the thing.
As you rightly said, we don't have experience neither with Efficamtin nor with mavacamten. And we have, you rightly said that they are for obstructive disease. The recently in ESC, the MAPL SCM was with Efficamtin showing increase in VO2 max compared to metoprolol, indicating that if you have to choose between the two, probably Efficamtin may be a better thing even on a standalone basis. Although guidelines always say after metoprolol, after beta blocker. The MAPL HCM was the Odyssey HCM was what Milind Desai presented. In non-obstructive hypertrophic cardiomyopathy, mavacamten has no role. It doesn't improve the VO2 max and doesn't improve the exercise tolerance. So the trials which have shown a reduction in the LVOT, the Explorer HCM and Valor HCM, both are with mavacamten, and both have shown actually a significant reduction, almost 50% reduction in provocable as well as resting gradient, and increase in VO2 max and improvement in quality of life. There are data which were presented actually this time, some MRI data, some remodeling data, but I think we need to understand more about them.
The best form of treatment is surgery. That's the one which gives reliable results. Long-term studies are known. Even alcohol ablation is.
No, but the Valor SCM did show that need for septal reduction therapy is reduced by 80%. 80%. That was what was the Valor study. But the septal reduction, actually, there is another interesting happening. That is the transcatheter radiofrequency ablation of the septum. And that actually could be, if it is cost effective, under imaging, probably could be better a one-time solution to rather than giving drug. The Chinese actually have presented a couple of studies, good studies. In fact, some of them I reviewed as a reviewer, and I found that that was looking very promising to me.
Can I make a comment, sir? So there is a phase 2 trial which is showing the role of amycretin. It is an anti-obesity drug in HCM, both obstructive and non-obstructive. Has shown to decrease the gradients in the obstructives. But I think they're coming out with a phase 3 trial. So I think that can also be something.
Dr. Pahal, any comments? You are more focused on hypertrophic cardiomyopathy than any of us.
So, with the use of mavacamten, the centers have used it for a couple of years, feel that the need for surgery will go down.
Yeah.
So the ventricular may remodel over a period of few years, and the surgery may not be needed. Right? But I think we need long-term data before we can come to this.
That one is symptom relief, but the other one is the risk of sudden cardiac death, whether it is decreased with mavacamten, nobody knows. So the symptom relief will be much more with mavacamten. But you have to, because 40 to 50% of the death is sudden cardiac death, especially in younger people with sports and all that.
Since somebody was asking about a phenotype of hypertrophic cardiomyopathy unique to India, my own experience is there is a phenotype unique to India. Elderly women with MAC and intraventricular gradient.
Sigmoid.
Both actually, sigmoid as well as the reverse curvature. Uh, they have intraventricular gradient, they have mitral stenosis, they have MAC, and they are extremely symptomatic because of HFpEF. And I think we end up seeing at least 1 to 2 patients every month. They are all genotype negative, in fact, and the septum is markedly hypertrophied compared to the free wall. Um, they also have some degree of aortic annular calcification. So I don't know whether we should label it as hypertrophic cardiomyopathy, or we should say that this is degeneration of the fibrous skeleton of the myocardium, along with, because of hypertension, obesity, there is asymmetric hypertrophy of the septum. I don't know how we should call it, but it is a significant issue which we are seeing in particularly elderly females. MAC, aortic annular calcification, some increased velocity, markedly increased asymmetric septal hypertrophy in intraventricular gradient, and they are symptomatic because of HFpEF.
Great, sir. I think we move on to next session. We are serving hot tea and we can discuss everything there. This